two main papers that extensively look at gastroesophageal reflux. And the group from Duke with Dr. Cantu published that 76% of their patients had abnormal pH testing after transplant. We had a lower level of prevalence with 35% of the patients at 3 months and 42 at 12, and the proximal abnormality, particularly in supine, was in 20% of our patients. Dr. Cantu showed that patients that got early fundoplication that had reflux after transplant had a trend to later development of BOS, or actually they didn't have any BOS development within their time frame of follow-up. But also what is interesting from this, these actuarial curves is that patients with no history of reflux, as well as those with reflux but no surgery, tended to have a similar actuarial freedom from BOS. We tested pH findings at 3 months after transplant, and we noted that patients with abnormal pH testing at 3 months tended to have a significant earlier development of BOS. Although abnormal pH testing towards diagnosis of BOS within 12 months had a positive predictive value of only 47%. So the literature as of now has mostly looked at acid reflux using pH testing. The recent advent of impedance will need to be tested, and it will bring light on non-acid reflux likely. And in normal patients, as documented in this paper in 2006, the pharyngeal reflux episodes are 75% of the time non-acids, while the esophageal reflux episode are 87% of the times acid, and these are normal patients. What's another interesting paper that came out in 2004 is that omeprazole does not change the quantity and the number of the volume and the number of events of reflux, but just the pH quality of it. So it doesn't really change reflux. And what are the contents of the refluxate? Well, there are both gastric or from gastric or duodenal origin. They can be conjugated bile acids and pepsin, which are bioactive and cytotoxic at a pH lower than 4. They can have unconjugated bile acids, trypsin and lysolecithin, which are instead bioactive at a pH greater than 7. The literature is rich, particularly in the 80s, of animal models testing for the bioactivity of pepsin and bile acid and trypsin into the airway, as well as into the GI tract. And the results are that there is an association and a correlation towards the pH, as well as there seems to be a synergistic effect between the combination of one or two or more than two of these components. So in light of all this, more recently the groups involved in lung transplantation have been trying to diagnose microaspiration by testing biomarkers in the bronchoalveolar lavage or in exhaled breath condensate, as per Dr. Krishnan. And the biomarkers that have been tested are mostly pepsin and bile acids. The results have shown that the vast majority of the patients of lung transplant patients have a higher level of pepsin in their BALs, although that there is no adverse association between pepsin within the BAL and either early BOS, late BOS, inflammation, or acute rejection, as per the group from Leuven in Dr. Blando's patient population. Dr. Krishnan at the ISHLT in 2007 presented this paper looking again at pepsin within the exhaled breath condensate, and they quoted that nisin does affect the quantity that they will find, reducing it significantly from 4.4 nanograms per ml to 0.32. But but the group from Leuven tested both pepsin and bile acid and confirmed that likely bile acid will be the biomarker that will be associated with the potential adverse outcome. What we did in Toronto is looking at bile acids in serum and BAL within 24 hours in 30 patients to see if there was any correlation, and we did not find it, showing that likely bile acid is a good marker for reflux aspiration. And we went on and tested 271 samples from 120 patients. We tested them for bile acids, for a large group of cytokines, as well as surfactant proteins. We noted that patients, in looking at the association between bile acids and pH testing, that patients with bile acids in their BAL had a positive predictive value of 73% towards abnormal pH testing, while the other way around, abnormal pH testing had a lower positive predictive value towards presence of bile acids in the BAL. BOS patients with bronchiolitis obliterans, which is the clinical correlate for bronchiolitis obliterans, had significantly higher levels of bile acids in their BAL, and in particular, patients with early development of BOS within 12 months after transplant had significantly higher levels compared to patients that had developed BOS late. And we also tested that at one specific time point, at 3 months after transplant, and noted that the high levels of bile acids were associated with earlier BOS development, and therefore documented both a dose as well as a temporal association, which are two important factors to determine causality. There was a significant association between the correlation between the bile acids and most of the cytokines, and this relationship was actually dose-dependent in a biphasic fashion, where at high levels the TNF-alpha, IL-12, IL-1 beta were significantly elevated, while at low levels bile acid were associated with lower levels of TNF-alpha, IL-12, IL-1 beta, as well as interferon gamma and IL-2. Somewhat indicating that at high levels it seems to rev up the cytokine milieu, or at low levels it seems to depress it. Whether bile acids are a bad thing in the airways, it's well investigated in the literature, and it ranges from changes within the calcium channels to complete destruction of the type 2 pneumocytes. So in conclusion, IPF and BOS, which is a clinical correlate for bronchiolitis obliterans, are associated with gastroesophageal reflux. Bile acid testing in the bronchial district, whether in the BAL, sputum, or axial condensate, may be the best biomarker for microaspiration to be monitored towards adverse outcomes in lung disease. Having said all this, the standard yet is the two-channel pH testing, particularly the proximal pH testing is the only one that has been shown to have some association with what you may be finding in the sputum or BAL. And we probably need still quite some work to determine and standardize which one of the biomarkers will be the gold standard tool for detecting microaspiration. Thank you.